Up, let me introduce you to Dr. Jonathan Meyer. He's here at OU-HSC, OU Health Science Center. He's an assistant professor in the Department of Pediatrics, and he's a member of the Harold Ham Diabetes Center here at OU. He attended medical school in Galveston and did his residency in San Antonio. And after his residency, he joined OU for fellowship here at the OU Health Center and completed his fellowship in 2017. And he gives leadership to our CAH and DSD clinic called Succeed Clinic, Multidisciplinary Clinic, and also is heavily involved in medical education with our medical students and residents within our section. He will be speaking to us about Klinefelters and associated genetic anomalies. Thank you, Dr. Meyer. You ready? All right.
And you can take that handheld off the stand if you'd like better that way.
Okay, great. Do you want me to grab the?
Thank you.
Okay, great. Well, so thank you all. Very happy to be here today. 10 years ago, Pestle, I did my first presentation as a resident in San Antonio, and so this conference means a lot to me personally. A great chance for, of course, career development, meeting people, all that stuff. So happy to be here 10 years later. 9 years ago, we had Pestle in Oklahoma City. I know this because as I was trying to save these slides to a right flash drive, I found a random one, loaded it, saw what else is on there, and it was the 2014 Oklahoma City Pestola. So blast to the past right here. So with that being said, welcome back to Oklahoma City after nine years, and let's get started about Klinefelter. I have no disclosures, and during this presentation, I'd just like to review the core clinical and biochemical findings of Klinefelter, develop plans for diagnosis and screening for complications throughout the lifetime of the pediatric patient, evaluate evidence for initiation, dosing, and duration of testosterone therapy in children and adolescents, and discuss fertility to some extent. And then very briefly review sort of variations or other sort of associated genetic anomalies. So I'm going to just say a few things really quickly. I wanted to talk about Klinefelter. I actually thought about talking about it last year as well, but I thought this year was good. Klinefelter is a condition that I feel like a lot of people know a little bit about. So probably in medical school we're talking about, we know this is probably a condition where there's an extra X chromosome. These patients are probably taller, maybe have more sort of female appearing features, maybe need testosterone treatment. And even during our education, I feel like that's kind of where we are. Of course, endocrinologists, we go above and beyond that. But throughout the literature, there have not really been great guidelines to talk about sort of how best we should approach these situations, but with more specific screening, treatment options, things like that. And so certainly people have written good articles about Klinefelter over the years, but probably some of the best and most recent guidelines are coming now from the European Society of Endocrinology, and these are from 2021. And so just for full disclosure, a lot of this presentation will focus on these guidelines and I'll kind of make them more to the pediatric population. And then furthermore, I really do want to focus on the pediatric population. There, of course, will be a lot in the adult world, and I'll not focus on things such as probably things like prostate cancer and really more the really deep down fertility aspects of Klinefelter. So we generally think of this as 47XXY karyotype. For the purposes, most people actually say Klinefelter probably is just extra X material. And this is primarily due to non-disjunction of sex chromosomes. So this is not something that, of course, is going to be genetically inherited in the normal autosomal dominant recessive sense, Mendelian inheritance. 50% are usually due to paternal non-disjunction, and the other 50% are mostly maternal non-disjunction. It can be associated with early mitotic divisions as well. There does seem to be a correlation with advanced maternal and paternal age. When we look at the prevalence, we're probably looking at about 1 to 500 to 1,000 males. I've seen 600, 700, anywhere in that range. And a lot of that's because we don't really know for sure. 50-75% of affected males never actually receive a diagnosis to the best of our estimates. And during childhood, which is of course what we're concerned about as pediatric endos, really we only diagnose about 10% of these. And so there's a lot that we, of course, that we miss during the childhood. Now, when we think about 47XXY, of course, this is going to be most of our diagnoses. 10 to 20% are others, and these include the mosaicisms. Most of them are 47XXY and 46XY. We have structurally normal X chromosomes, and we have the higher grade aneuploidies. So there's multiple X, either 3 or 4 X chromosomes. And for the purposes of this presentation going forward, when I talk about Klinefelter, I'll be referring mostly to 47XXY. What's interesting about this is really up to, when they've done studies on this, up to 0.9% of male blastocysts examined during pre-implantation test positive for Klinefelter. And so again, this is probably more common than we think. With that being said, there could be a selection bias because these patients are likely older, looking, probably have infertility to some extent as well. But it does give us some clue to how often we actually may be seeing this. So we have implications of the extra X chromosome. And so Dr. Barron mentioned this a little bit earlier, so seeing some of my thunder here, but it's obviously a great talk. So 2 things I want to focus on. We have an excess of the short stature homeobox gene or the SHOX gene. We know this has an increase in height. So as he mentioned, I was going to mention as well, there's about 50% of the genes on the X chromosome that do not get inactivated. And so these patients have the extra SHOX gene. So basically have 3 copies of this. And this inactivation, of course, may vary from patient to patient, but SHOX, generally speaking, is one that's not affected by inactivation. And then there's possible CAG repeats on androgen receptor. And so the studies have suggested this is actually not more common in Klinefelter compared to the general population. But for those actually with Klinefelter, if they happen to have more CAG repeats, this can certainly lead to increased androgen resistance. And so really the crux of the complications with Klinefelter rests in these conditions. The first one being the X chromosome, we have extra gene dosage. How much does affect our comorbidities, we don't know for sure, but certainly that's come to play. And then secondly, what sort of role does testosterone play? Those with the increased androgen resistance, of course, probably have more severe symptoms. So this is obviously a good chart, a large chart showing what we look at for symptomatology from prenatal into adulthood. And obviously I want to focus on this through adolescence. And of course, we don't diagnose them very often early on. In terms of symptomatology, this is what I have highlighted. The earliest symptoms are oftentimes cryptorchidism or undescended testes and micropenis. And of course, this can persist throughout the lifespan. As we move on to children and kind of pre-puberty, we start seeing more things. We start seeing tall stature, increased fat and lean mass. We start seeing during school age speech and learning difficulties, and then sometimes behavioral difficulties as well. And then once we get to adolescence, more and more symptoms start to appear. We start seeing issues with puberty. We continue to see the tall stature. We may see things like gynecomastia. We start seeing probably signs of maybe some metabolic syndrome as well. And everything, if we're going to see it, may get worse as the lifespan progresses. And so this is probably typical for a lot of genetic conditions, but for Klinefelter, it starts to become more and more apparent, which is why, of course, we get diagnosed oftentimes later in life. Just really quickly too, this old picture from Williams kind of shows some things we're talking about with Klinefelter. On the left, we have the classic 47XXY karyotype, and on the right, we have the mosaic form. Clearly, the man on the right has more signs of androgen. So we have, of course, more body hair, probably less, what appears to be less sort of fat mass, more body hair, larger penis size, probably more muscle mass as well, just in general. And so these are some of the things we see the difference between mosaicism as well as the classic form. With it being said, even the man on the right does have some of the, it's hard to tell height per se in this picture, but you can see some of the classic signs as well. Okay, so looking at the guidelines, the first thing is, of course, to make the diagnosis, we always need to confirm the karyotype. And I think everyone is in agreement on this. We're doing more and more prenatal testing. And so NIPT, or non-invasive prenatal testing, is becoming a very big part of what we do in the OB world. And so this can be done as early as, I believe, 10 to 12 weeks. And so if this is suggestive of Klinefelter syndrome, genetic counseling is recommended. If we do a karyotype, but we strongly suspect we do a karyotype and it does not appear to be Klinefelter, a microarray could be helpful. This may help us determine some, kind of smaller changes in the chromosomes. We could always consider doing the CAG polymorphism for the androgen receptor gene. This is not routinely recommended, but something if we feel like there is hypogonadism early in life and we otherwise suspect Klinefelter, may be helpful. And so I'll move on now to the complications of Klinefelter. Starting off with bone, there is a risk for osteopenia, osteoporosis. And if we have vitamin D deficiency, this can present pretty early. For those patients, we actually check a vitamin D level or suspect that and it's low. A DEXA scan is probably worthwhile as well, and then should be checked every few years. So I'll say this. Well, so one small study that this article references had 7 out of 40 boys actually have Z-scores of less than ST on the DEXA with low vitamin D and elevated PTH levels. So not a clear-cut answer to, obviously not all patients have vitamin D deficiency and bone health issues, but certainly it can happen. And so it's something we need to watch for and will probably present more and more as these kids get older. We worry about body composition. And again, this is probably multifactorial. What we know about this is that there is elevated body mass, fat mass present in early childhood and adolescence, sometimes despite a normal BMI, which is kind of interesting. And so if we break down sort of why this is the case, we wonder, we've classically thought, well, maybe there's just low testosterone levels throughout the course of this, the course of Klinefelter, starting off with infancy and early childhood. But certainly wonder about psychosocial concerns as well. If these patients are already, becoming a little bit more obese, maybe they're not as likely to want to, take part in activities, exercise, maybe eat as healthy as well. And then we do worry about, again, other gene dosing from the X chromosome. So are there other genes on the X chromosome not inactivated, depending on the patient, that are contributing as well? And that, again, is more, where kind of more research is needed and is being done. Psychological aspects are, of course, very important as well. We believe these patients generally have very good cognition. And so we don't expect them to have, generally speaking, a sort of, intellectual disability or things along those lines. And that's been my experience as well, treating many of these patients. When we think of what really is affected, think of verbal issues. So we think of language development, visual spatial issues as well. Young children, really speech delay is a big deal. And so we want to get them into speech therapy early on if there's any kind of issues with that. These patients are probably a higher risk as well for ADHD and attention issues. And so again, if that's a concern that needs to be addressed and treated early on. And so tapping them into resources starting at school age is going to be very important for these children. Okay. So growth and puberty. So in terms of growth, boys with Klinefelter tend to have normal growth, usually again for the first several years of life. And then after maybe age 6 to 8, tend to start growing quite a bit taller. Puberty also starts usually at the same time as Klinefelter. So there's not a consistent finding of either early or delayed puberty, which is very helpful. But as many of you know, puberty then will stall out over several years. During this time, we have gonadotropins increasing with testosterone, which then will also kind of plateau. And then inhibin B will do something similar. So increase initially and then decline significantly after pubertal onset. And so the recommendation, of course, is to get regular testosterone and gonadotropins over the course of puberty, but how often, maybe a little bit unclear. So we also have micropenis quite often in Klinefelter, and that was shown by the picture I showed earlier. Generally, we say micropenis is a SPL of under 2.5 centimeters. Different people may have slightly different definitions. Best but most common definition. That's what I use in my practice. This can be found up to 70% of infants with Klinefelter. And so these patients, we need to consider testosterone treatment on a case-by-case basis. This is usually a 3-month course. And again, this is usually thought of as more of a cosmetic treatment with a net benefit, of an immediate benefit, and then maybe some regression of size, but an overall net benefit. However, as we'll talk about a little bit later, there may be some other benefits as well in this population. Klinefelter is also the most common cause of cryptorchidism in males, or genetic cause, I should say. So we think it's about maybe 1.3% in cryptorchidism in general. And for those that have bilateral, or there's so cryptorchidism, sorry, after a year of life, up to 2 years of life, is up to 2.6%. And if sort of retrospective study, maybe about 30% or so with patients with Klinefelter actually have a history of undescended testes. So that's a pretty good clue to that this is a diagnosis we need to take a look at. And so the recommendation is actually to go ahead and get a karyotype if cryptorchidism is not resolving prior to surgery, which would be about within the first year of life. For these patients, we consider obtaining testosterone gonadotropin levels during mini puberty. They may help the diagnosis a little bit, but it's not something that's routinely recommended. And again, I probably would not do this routinely unless we're trying to work up something like micropenis. For fertility, what we normally see as we get through adolescence is extensive fibrosis and hyalinization of the seminiferous tubules. We actually have hyperplasia of the Leydig cells, and we have sort of regression of the German Sertoli cells. So the whole architecture is starting to be affected during adolescence. And so the recommendation is fertility options should be discussed to all adolescents at some point. And so if the patient does decide to proceed with fertility evaluation, which again should be done after significant counseling, the first step would be a semen sample, look for motile spermatozoa. And then with additional counseling, they may want to consider testicular sperm extraction followed by the cryopreservation. The two most common types, of course, are going to be the multifocal and microdissection. The microdissection is going to be a much more sort of, I guess, complex or involved surgery involving imaging to look for potential spermatozoa. The recommendation is also to consider testicular ultrasound during puberty. This, again, probably does not change any sort of clinical management in most cases, but may give a clue to the actual architecture of the testes to make sure there's nothing grossly abnormal at that time. So one interesting fact about fertility is that in some studies, adolescents up to 14 years, spermatozoa are not very common. And again, this is probably as they're very early in puberty, going through puberty. The thought is maybe if we look at this very early on, we can actually have a better chance of getting sort of intact or viable spermatozoa. However, if we waited a few years up to age 19, much higher chance of actually getting spermatozoa. And if we look at beyond that, up to 30 years of age, rates are very comparable. So as pediatric endos, it does give us some sort of assurance that we don't have to rush this right away. We can wait in most patients until we get into their 20s if so desired. Interestingly, some lab tests also kind of portend fertility as well. So if we have a very low testosterone, less than 7.5, it's very unlikely there's going to be any sperm retrieval. If there's a testosterone over 7.5, And an LH is very high, also very unlikely, but an LH under 17.5 in that setting is much more suggestive that we'll have some chance of viable spermatozoa. Gynecomastia is something that, if we look at the lifespan, is found in about a third of adult patients. We don't really know the prevalence of adolescents. Now, if we look at, of course, our general population, we know a lot of adolescent boys in general have some degree of breast budding. So the suspicion is actually pretty high during puberty. And again, we think this is probably due to imbalance of testosterone and estrogen. And again, going back to like the core concept here, we have, how is our androgen receptor gene affected? And what's our X chromosome activation status? So what genes are producing extra doses on the X chromosome? And so recommendation is really breast exam about every 6 to 12 months during puberty, and as an adult, probably every 2 years or so. And I will touch base on this a little bit later in the presentation. So how about neoplasia, just very briefly. So breast cancer is certainly higher in Klinefelter compared to the general population, about 30 times higher actually. So it's not negligible, but the lifelong risk is still only like 1%. So again, it may be higher relative, but it's not, the absolute risk is still pretty low. And these are mostly extragonadal germ cell tumors. They mostly reside within the mediastinum, and they can't produce HCG. So if we have a Klinefelter patient with precocious puberty, it is almost certainly worth it to get an HCG level just to make sure we're not missing something like this. All right, so now the fun part, testosterone replacement. And this is, I think, where over the years, I've kind of tried to figure out what the best treatment is, the best course treatment for our patients. And so let's look at some of the data on this. So clear recommendation, we're gonna start with the least controversial to the more controversial. We recommend to start testosterone in the setting of delayed puberty. This is true for, of course, all of our adolescent patients. If we're 14, not having signs of puberty, that can always be considered usually a short course, but certainly in Klinefelter may want to do longer course than that. And then in addition, we're looking at hypogonadism. So how do we define that? We're probably looking at consistent low to low normal testosterone levels and an elevation at LH over 2 standard deviations above the reference range. We know that 25% of patients have testosterone levels below normal range. And so these are patients that right away would probably benefit from testosterone a little bit earlier rather than later. And most of you are probably aware of the fertility really should be discussed prior to initiation of testosterone therapy. Endogenous production of LH is very important for fertility. And so the thought is if we're, of course, giving testosterone, we're going to depress, whatever, appropriate access we have at the time, whatever, fertility we have. Now, this is kind of interesting topic as well, because we know these patients are not going to generally be very fertile. So this is a recommendation, but in practice, it may not be quite as important. And so we're looking at testosterone guidelines. The best guidelines are still coming from the adult world, and so I'm going to touch base on that right now. These are 2 I put up because these are 2 that we'd probably use in our clinic. The first one, testosterone enanthate or cypionate, is going to be our injection. And so that depends probably more based on what you have available. We usually use cypionate because we have that available. And of course, some of the benefits of that are that it really is relatively inexpensive. We can give very precise dosing with this without risk of exposing others in the family to testosterone. But there are some possible side effects as well. Now, with the gels, I put this on here as well. It probably is theoretically easier to give, but there are some concerns as well. One of the big concerns with that is that they're not approved for pediatrics. And so if we're using them under 18, they're going to be off-label. But if we do use them, we want to start with the very small doses. That's kind of what we're looking to do for our patients that are approaching 18 or over 18. If we're using injections, we usually start at 50 to 100 milligrams IM monthly. And the thought is this will kind of support secondary sexual characteristics, really should not affect growth potential meaningfully. And then we oftentimes don't have to check T levels during this time. There are some side effects, and these are kind of very common things, but of note, erythrocytosis, acne, and gynecomastia. I have seen that once or twice. And one of the big issues with injections is the initial dose is super therapeutic, and then it drops down into more of the therapeutic and maybe even subtherapeutic range over the course of the duration. So in adolescents, we normally would increase at adulthood, so 18, or when growth plates have fused. And we would probably, once we get to that adult dose, start to increase about every 6 to 12 months. Once we really are moving to adulthood, we want to check every 6 months as well. And the goal is to really keep the levels within 350 to 600 nanograms per deciliter, aiming for kind of a normal to low normal range at least. And then hematocrit can also be checked at the same time. Now, a few more controversial aspects. So in infants, probably some of the best data is coming from, in children, infants in general, probably some of the best data is coming from Colorado, as well as Judith Rotz's group in Philadelphia. So many of you know about this study. This is a prospective randomized trial of 20 infants, 6 to 15 weeks with Klinefelter, received 25 times 3 months versus no treatment. And so in the untreated group, there's an increase in fat mass Z-scores. The treated boys also had greater increases in total mass and fat-free mass, stretched penile length, and growth velocity. And then at 5 months of age, adiposity in untreated Klinefelter infants was 26.7 compared to 23.2 in healthy male infants. And between the healthy male infants and the treated boys, there was no significant difference, and there were really no adverse events during this study. This is encouraging for us to suggest that maybe during this time, we can think about testosterone treatment, but again, this is a small study, and we'll kind of see what else develops. My understanding is I'm assuming they're probably following some of this cohort over time. Last I corresponded with them, but I could be incorrect about that. Now, in children, and this is more the 4 to 12, there's three papers that came out from this cohort. The first one was really just looking at the percent body fat standard deviation score, which was lower in treated individuals. The secondary outcomes also showed lower triglycerides, lower total cholesterol, and HDL, and advanced bone age in treated boys. So it does suggest there's going to be some benefit from a sort of body mass perspective in the treated kids. The second paper that came out, again, 84 boys, ages 4 to 12, was OX versus placebo for 2 years. These treated patients had improvement in visual motor function, but there's no difference in upper limb speed strength, hand strength, or grip strength is really what they're looking at, or finger strength. And I thought there was maybe there's going to be some motor deficits in Klinefelter as well. And so this is trying to look really more at the motor aspects. And so secondary endpoints included looking at psychosocial function. So there was some improvement there, but no improvement in cognition or aggressive behaviors. The third paper that came out, again, same cohort. And so the OX-treated group had 20 times higher odds of reaching gonarchy and 28 times pubarchy. These are both at a younger age in the untreated group. Hormones are not significantly different. And so there really is a true concern about early puberty. And the thought is overall, the early puberty probably outweighs any other benefits. Certainly more studies to come. Many other people looked at testosterone in children, and when they've kind of looked at been retrospective studies, a lot of the patients receiving testosterone received it early in life for micropenis specifically. So there are some suggestions that there are some good outcomes with testosterone in children. However, again, these are patients that may be skewed toward already having lower testosterone levels at baseline. So additional considerations for Klinefelter. Autoimmunity has been reported. Those of you who worked with me before know that I usually do like to check thyroid tests because of this potential risk of autoimmunity on patients. One of the more recent studies about this actually not seeing that thyroid functions seem to be affected significantly. Free T4 may be a little bit lower in these patients, but other thyroid labs seem to be okay without other obvious clinical symptoms of hypothyroidism. And so I think getting thyroid probably one time during childhood is probably fine. There's going to be increased risk of thrombosis. It does not seem to be associated with testosterone therapy. And this is going to be something that we may see in the pediatric population, but it's going to be more likely to be seen in the adults. So I don't worry about that so much for our patients. And again, we want to focus on having a multidisciplinary clinic. And so this includes many specialties. Disclosure is something that also can happen over time. So at the initial visit, explain to families about Klinefelter, talking about how, again, this is something that we really cannot control. This is likely non-disjunction, not family's fault, what to expect as they proceed. And then at subsequent visits, just talk about more and more some of the psychosocial aspects they get a little bit older, starting to talk about testosterone and puberty and fertility as they get older as well. So this is something that happens over time. And then transition to adulthood, of course, should be well thought out. And I've been asked about this before as well. I think Dr. Bangdu also talked about transition with Nunes, for instance, or at least was asked that question. In my mind, if I can get our patients at 18 years of age, they're on a good dose of testosterone, we've discussed fertility, we've done additional screening to rule out other metabolic syndrome or things like that. They've been tapped into resources appropriately with our psychologists or other people that they need. I feel like I've done my job. And so at that point, really, it's just getting them to see adult urology for fertility, which usually is kind of started to happen at that point. And so I feel very confident they'll do well as adults. And so to finish up here, I wanted to say, so I kind of went through and tried to create this for the pediatric population. And this is kind of what we're looking to introduce into our clinic as well. So in infancy, we're obviously confirming with the karyotype at any age if we suspect the diagnosis. We want to consider testosterone therapy at this point just for micropenis, but maybe over time there's going to be rules for other indications as well. Discuss with family initial visit for psychology down the road. Discuss kind of some of the issues with fertility and metabolic health as well. Around school age, we'll add on usually psychology visits. And so looking at how they're doing in school, what additional help do they need? If before that, if they need speech therapy, of course, we can do things along those lines. And then once we get to 9 to 11, of course, in the general pediatrics population, we start thinking about, okay, we probably want to do our routine screening for lipids. So let's just add that on at that point. So let's just do our routine screening. CMP lipids, A1C, probably that's a good time to get a vitamin D. It's a good time to get TFTs if you want to do that. And then we'll follow up on vitamin D if we're low. And then we can also start getting our gonadotropins as well, LH-FSH and testosterone. Once we hit puberty, again, we're confirming any suspected diagnosis. We start testosterone therapy in most cases. We'll wait until we have a very clear low T. Ideally be 2 checks in the morning. But if it's very clear, that's fine to go ahead and start. And again, I usually prefer 100 milligrams monthly because the thought is that this is going to be enough to kind of start things. And we want to go on the lower side to preserve growth, but again, these patients are tall to begin with. So if we suppress that a tiny bit, is probably not the end of the world. We get our metabolic labs yearly or as needed. And then, of course, we're going to start discussing fertility because we're looking to start testosterone as well. At 18, we're looking at adulthood. So we're going to start moving to adulthood if we're not, or adult dosing for T if we haven't already done that. And so we're going to start increasing that every 6 months or so. And then for metabolic health, we'll be checking as well every 6 months. And these levels should be checked in between testosterone doses. If we're giving a monthly dose, should be every 2 weeks. We're giving, of course, every 2 weeks, and they should be checked in between a week after injections been given. Now, change of pace, just to finish up here. We have some tetrasomies and pentasomies as well. And the big thing I want you to take away from this is that although these conditions are treated very similarly to 47XXY Klinefelter, there is a little bit of a difference. They're probably more severe. And so the prevalence, as you can see here, is much lower, but this is probably a little bit more accurate in the sense that these are more commonly diagnosed because the symptomatology is more severe. Again, we have developmental delays. We do have more cognitive impairments in these patients as well. And we would treat with testosterone along the same lines as 47XXY Klinefelter. One of the best reviews is still the paper from Tartaglia et al. In 2012 regarding this. And so it's interesting in that paper is they make the point that if we set all these patients aside to our own basket, they may not get the services, they may not get the diagnosis, the research that's needed for this population. And so a lot of these patients are kind of involved with Klinefelter studies as well. So while yes, there is a difference, a lot of times will be included with the research. And I believe they actually have been included with some of the studies I actually mentioned earlier. And then I'll finish up with 47XYY, which is actually quite a bit different than everything I've talked about so far. But this is something that probably many of you may have a patient or two with this, or maybe multiple patients with XYY. And again, one of the best reviews is coming from 2014, Bardsley et al., where again, the prevalence is much lower than the tetrasomies and pentasomies. But again, like Klinefelter 47XY, 45% are never actually diagnosed. And so when you think about these patients, we think about, again, tall stature, large testes. And what's interesting, they have a lot of other comorbidities. These can include things like asthma and seizures. And so we're focused on, of course, treating the comorbidities. Testosterone level is not routinely needed for these patients. Now, one other note is historically, these patients have been known to have increased antisocial behavior. And these studies, of course, are pretty poorly done. As I think many of you know, I think a lot of like prison studies, things like that. What it looks like, it's not really due to the testosterone levels. It's probably just more due to, kind of predisposition toward things like autism spectrum and ADHD. So with that being said, I'm going to do a quick plug for our program. As Dr. George mentioned, I do head our 6D clinic, our DSD clinic. And so I see many of these patients for Oklahoma and surrounding areas. My contact information is here. Please feel free to reach out. And with that being said, I'll take questions.
Thank you, Dr. Meyer, for that comprehensive, wonderful talk. And is there any questions on the? Now, please raise your hand and I'll have to bring the mic to you. Just for the people to hear on Zoom, if you have any questions. Sure.
Do you have Klinefelter patients who grow relatively slowly and they have a delay in bone age? And what's the percentage of all Klinefelter you've seen?
Yep. So I think everyone heard that. What percentage or kind of do you have patients with really delayed bone age? And so we have a couple. So this is pretty uncommon. Most of our Klinefelter patients are traditionally tall and probably more on the obese side, although again, it has some thin ones as well. It's always different. But yeah, I have a few that are definitely on the smaller side. And so for those patients, we're kind of watching additional growth. And I think I've even done additional growth workup for those patients as well, because it doesn't fit the typical picture.